We know what it looks like. This will be familiar to most of you. These are the familiar pathological hallmarks of the disease in the brain. This gunk called amyloid accumulating outside the cells on the left, and these peculiar misshapen nerve cells that have aggregates of a protein called tau that's abnormally chemically modified, phosphorylated in these so-called neurofibrillary tangles on the right. This is what the disease looks like. This is how the brain ends up. We don't know why. We do know it's a chronic disease. We do know it begins sometime in middle life, not old age, okay, for most people. And that its earliest symptoms are barely noticeable and may be viewed as normal for age. But we'd really like to be intervening before we even have those kinds of preliminary symptoms. Now, as the symptoms become more severe, they may be recognized as mild cognitive impairment, and we heard a little bit about that this morning. That's a stage in the development of the symptomatic end of this disease. So I've sort of drawn a picture here for you showing how the disease, we call it latent because it's not being expressed in symptoms, the symptoms that help us to recognize the presence of the disease. That's the green part. And then you get to a point where people may be having some sense that they're not as sharp as they were, and they're worried about their memory and other cognitive faculties. And I need to emphasize that certainly not everybody who has those kinds of worries will end up with Alzheimer's dementia. But among the people who do, there's very commonly a subjective cognitive impairment stage. And then you get to the point where people really do have symptoms, although they're not necessarily disabling. And that's what we call mild cognitive impairment, or MCI. And Dr. Stoltz has told you that there's a great deal of interest in this as a precursor of dementia, although I think it's worth noting that not all cases of MCI do progress to dementia, and certainly not all of them progress to Alzheimer's disease. But nowadays, we are able to study the biology of the brain as well as the symptoms, and better able to identify who in fact has Alzheimer's disease causing their MCI, and there's a category now called MCI due to Alzheimer's disease, for which there actually are research diagnostic criteria. So MCI is of great interest because it would be potentially a place where we could intervene and prevent a lot of additional morbidity and loss of function. But unfortunately, as Dr. Stoltz has told you, the few pharmacological or drug treatments that we have that have any effect on the dementia have not been shown to be helpful necessarily in the treatment of mild cognitive impairment, and importantly, in one major trial at least, they do not prevent the progression of MCI to Alzheimer type dementia. They may postpone it for a little while, but they do not prevent it. Okay. So one of the reasons for the frustrating part about all this is that as we who try to work in this area, is that by the time we have symptoms, the train may have already left the station. Now that's a terrible thing to say, isn't it? But what I'm really trying to suggest is that there's so much accumulated. The brain is an organ that has a lot of resilience and reserve. You can lose a lot of your connections in your nerve cells in the brain before you begin to develop symptoms. And by the time you develop the symptoms, for example, of mild cognitive impairment, and this is just one of several papers that have made this point, if you were to examine the brains of these people, as sometimes happens when they die with this condition of MCI, they're indistinguishable from the brains of people who are dying with Alzheimer's disease, dementia. So there's already massive damage to the integrity of the brain in people with MCI. Probably one of the reasons that we've had such difficulty in coming up with a cure is you're trying to deal with an organ that has already suffered extensive damage that is, if not completely irreversible, certainly very, very difficult to reverse. And the same is probably true at the stage of MCI. So for some years now, I've been convinced that the place we really want to be looking is upstream from MCI in this latent or pre-symptomatic phase of the illness. Ultimately, we have to find ways to attack the disease in its pre-symptomatic stage. So just to remind you once again, that's the green and maybe the yellow end of this spectrum here. And the good news is we're talking about at least 20 or 25 years of opportunity. The hard part about doing this is how do you know if you're making a difference other than waiting 15 years to find out if so-and-so ends up with symptoms, okay? Because there actually are changes going on in the brain 15 years earlier, okay? But you can't rely on symptoms to find out whether your treatment is actually doing anything to make a difference in slowing it down. Slowing it down is what we want. Slowing it down means delaying the onset of the symptoms. And this is an instance where delay in onset, it's kind of you get 2 wins for the price of 1. First of all, of course, you get more years of happy, healthy life before you have symptoms. That's sort of a no-brainer. I shouldn't say no-brainer. That's obvious. But the other thing that people sometimes forget is that this is primarily a disease of very late life. The most common age at which to develop this disease is probably in the 80s or even in the early 90s, as people are living that long now. So it's not hard to imagine that if you could postpone the onset by, let's say, 5 years, a great many individuals, this is an age at which, for better or worse, rates of mortality are very high and people are dying from other causes. So you may very well be able to escape the onset of the dementia by postponing it for only a few years and never know that you were actually suffering with this disease because it wasn't yet being expressed as symptoms. So that's kind of the utopian vision. You postpone it long enough, nobody will get it. Gotta look here in the green. Okay, how do we do it? So I like to think of this question in terms of sort of 2 broad approaches. One is to change lifestyles and behaviors and anything else that you can find that's currently available to us. That we already know from in statistical terms are associated with lessened risk of dementia. We'll talk a little bit about what these lifestyle changes are, although you've heard a wonderful presentation from a couple of our speakers already this morning. I don't have an awful lot to add to that. The second is what we'd really like to do, if it were possible, would be to develop some kind of chemical intervention that would slow down the disease process itself in the way that many powerful medicines are able to attack other kinds of chronic diseases. So we need a statin for Alzheimer's disease, for example. Some of the diseases that are used for treatment of hypercholesterolemia, for example, have now been proven in many experiments to actually reduce morbidity and mortality from heart disease and stroke. Okay, they do that by intervening on part of the pathology of the disease, which is the buildup of cholesterol in the arteries, and you take a pill every night after you have your steak. I actually had a cardiologist say that to me one night. He wanted to take me out for a steak dinner. I said, "Aren't you worried?" He said, "No, I'll just take a little Lipitor afterwards." Perhaps a little bit cynical, but there is no doubt that the availability of some of these very powerful medicines has actually brought about significant reduction in heart disease, and we can do the same if we can find an equivalent treatment for Alzheimer's disease. So ultimately, I'm hoping that we will come up with something like that, because it's very hard to get people to change their behavior. Have you noticed? It's all we have now, and we have to emphasize it and work very hard at it and never give up, but it's a tough road. Regular exercise, already been mentioned. Probably the most important single behavioral modification. And you've heard wonderful suggestions this morning on ways to increase physical activity and get a regular exercise. And it's probably, after age itself, the most important single risk modification strategy that we have, because in part it will help reduce weight, it will help control blood pressure, it will reduce type 2 diabetes. But these are ends in themselves as well, because all of these are risk factors for Alzheimer type dementia. So if you look at this, you can sort of see that my favorite expression here, which is what's good for the heart is good for the brain. So lots of reasons to be trying to adopt these kinds of preventive health promoting lifestyles. Prevention of Alzheimer's disease not being the least among them.